Welcome to Surviving and Thriving in Residency, brought to you by PracticeLink, where we help residents and fellows prepare for their career journey with confidence. I'm your host, Charles Lowry, Director of GME Relations here at PracticeLink. Today on Surviving and Thriving in Residency, I'm joined by Dr. Rohit Bhan, an orthopedic surgery resident at the University of Iowa. Dr. Bhan brings a rich academic and research background to his training. He completed his medical degree at Stony Brook University School of Medicine, and before that earned a master's in biomedical sciences from the Icahn School of Medicine at Mount Sinai and a bachelor's degree in chemistry from New York University. His path through research has been especially strong. He has worked extensively in spine surgery research, including serving as a spine research scholar at Washington University in St. Louis, and he has contributed to numerous publications spanning adult and pediatric spinal deformity, tumor, and revision surgery. Today, we're going to explore his journey into medicine, his transition from student to resident, what life is really like inside an orthopedic residency program, the importance of mentorship, how to balance research with clinical training, and strategies for staying grounded, mind, body, and spirit through one of the most demanding chapters of a physician's career. Welcome to the program, Dr. Bhan. I'm very happy to have you.
Please call me Rohit, and thank you. Happy to be here.
Yeah, thanks. So let's just start from the beginning. And what originally drew you into medicine, and at what point did you know this was going to be your career path?
So I would say what drew me into medicine, believe it or not, it was that show House, that medical mystery show or whatever. I don't know, for whatever reason, I really liked it. I think my mom took notice of that. But anyway, I went to college, and then I was a chemistry major. I was doing colloidal science research, this, that. But I wasn't focused. I was thinking, maybe I'll do computer science, or maybe I'll try finance, or maybe I'll do consulting or accounting or this and that or whatever. So anyway, I wavered around and didn't really end up in a really clear spot by the time college ended. So I ended up going to graduate school for 2 years, as you mentioned, at Mount Sinai in New York. I did some cancer research for 2 years, and then that kind of was a way for me to figure out if I wanted to pursue a career in research as a basic scientist doing bench work, or maybe go to medical school, because I did science and I did medicine. And then maybe I was just in the lab too many hours, too late, playing with a petri dish with cells on it or doing too many Western blots. And I was like, you know what? I think these cells come from people, and I think I'm a little bit more interested in the people. So that I took a year of clinical research after graduate school at NYU. I was working in rheumatology. We were doing clinical trials for lupus patients. So I had already applied to medical school, but to kind of answer your question about when I knew that I wanted to be a doctor, there was a patient that came in. She had bad lupus nephritis, which is an autoimmune disease, and it can affect the kidneys. So this person ended up getting a kidney transplant, and they're coming in for a clinical visit, and then someone's rattling off their vitals, and they say this person's blood pressure was 190 over 100, their heart rate is this and that, blah, blah, and whatever. So they're just talking about her. And then I'm like, hold on. And I'm just a research person. What do I know, right? So I'm like, hold on, I just have a question. You said her blood pressure was 190 over 100. I've had a family member that had a stroke, and I was told that their blood pressure was 200 over 100 at that time. Is this person at risk of having a stroke? And everyone was kind of like, oh, wow, what's going on here? And then essentially this person had a kidney transplant from a donor list. So I don't know transplant medicine much at all. I think I probably knew it better in medical school. But anyway, they're usually on rejection medicines, probably blood pressure medications as well, probably in the form of an ACE inhibitor or a beta blocker or whatever. So it turns out that whatever medicine that she was on, she didn't like the way it made her feel. So she wasn't taking it. So she was at risk of basically blowing through her transplanted kidney from a donor list, not from a family member, because she wasn't taking her blood pressure medication, and she didn't like how it made her feel. And I'm just just a research person. What do I know? I had gone to graduate school. I obviously wasn't a doctor like these people, and I just made some little observation, and I felt whatever, they changed her medicine, this, that. And she came back a couple months later, and she was doing great. Her blood pressure was normal, so she didn't blow through her kidney. She didn't end up on dialysis. At least that was years ago. Who knows what happened now? But yeah, I kind of felt a little bit of knowledge really made an impact in that person's life. And that's when I was I'm going to be a doctor.
Yeah, it would be interesting to see where she is today and how she's doing, right? It would be interesting if you could track that kidney somehow. So if you look back, what prepared you the most for medical school?
prepared me for medical school? I would say failure. I kind of alluded to it before, but honestly speaking, I wasn't like the best student in college. As I mentioned, I was like kind of distracted. I didn't really have focus. And that sort of fear of failure really drove me. That's largely why I ended up in graduate school, because I needed to really, bust my chops, work hard, get some good grades, show that I'm worth my weight in salt, at least. And then in med school, some people are married with kids, some people work a job to support themselves, some people have sick family members they're taking care of. I very fortunately did not have any of that. So I viewed medical school as my job. And I remember the feeling of feeling like I didn't really have a strong future ahead of me, that maybe my grades weren't good enough to be hireable at some fancy job somewhere, or like, was I even going to get into medical school? So that sort of fear of failure, fear of like not really having a career that I would want, drove me to study a lot. So I used to tell my friends and I used to tell myself, I don't have a job, so med school is my job. So I'm going to sit my butt in that chair, in the library, in the cubicle. I'm going to do all these flashcards. I'm going to do all these practice questions. And if that's what I need to do to get to where I need to go, then I'm going to do it. It's not like I have anything else to do.
So learning to study in medical school, it's a whole process in itself, right? You have to learn a whole new study process from what you've been taught from the first day you step into a classroom at 6 years old. It's a completely different study system.
Yeah, I think that's an entirely separate discussion. But medical school education, I'll be honest, I did not go to class very often. I would say where I went to medical school, I would estimate that somewhere between 75 to 90% of people did not go to class, especially if it wasn't mandatory. The reason why is that most of us use what you can generally call third-party resources, like different lecture videos or flashcards or practice questions that were not provided by the school. And this is not just unique to where I went to medical school. There's literature out there from like folks at Johns Hopkins, one of the pristine medical schools in the country, if not the world, saying that their medical school attendance rates for class is pretty low, and 90 some odd percent of their students say that they are using third-party resources. So I think it's a little different. People talk about drinking from a fire hose, but I think medical school is unique in that the study resources are literally made for you. You just like have to use them. So you could not catch me reading through a textbook and writing out notes by hand. Like that's never something that I did. Not that I really remember. There's like pre-made flashcards that some very generous, altruistic medical students, I think some of them were out in Utah actually. They made a flashcard deck on a program called Anki. And that basically had the entirety of medical school curriculum in a flashcard deck. And you just had to do the flashcards and you had to do the practice questions. And obviously you still have to go to your rotations and apply that knowledge. But that's essentially how I learned. A lot of flashcards and a lot of practice questions. So,
wow.
Yeah.
So tell me a little bit about, if you don't mind, thinking back on medical school, your first 2 years, and then your second 2 years, your clinical years. What were they like? And how was it stepping into your first rotation in a hospital as a student?
So the pre-clinical years, or the first 2 years, so to speak, again, it's kind of what I described. It was a lot of flashcards, it was a lot of practice questions, it was a lot of studying like that, a lot of third-party resource videos. Occasionally we had to go for some mandatory session to do one thing or the other, but that was fine. And then actual clinical rotations are obviously very different. So like, let's say someone has chest pain and shortness of breath and they have pain shooting down their left arm or whatever it is, or maybe they have some stomach ache as well. There's many things they could have, but you should probably consider that they may be having a heart attack or like a myocardial infarction. It's very different than hitting the spacebar on the flashcard program or clicking the multiple choice answer. You actually have to talk to this person and evaluate them and examine them and put that thing together. You're like, okay, you think it might be this, but what test do you order? How do you have a conversation with that person? So that's different. I think if it's not clear already, I'm a little bit of a chatterbox. So me chatting with patients was not too challenging, but it's definitely something you get good at and you have to practice, like what's a relevant question to ask, what's not a relevant question to ask. Before you go on your clinical rotations, they give you, I don't even remember what the acronym is called, but they tell you, there's an acronym that lists essentially all the different systems and thoughts you should be having going into a patient. And like vividly remember at one point talking to a patient during my psychiatry rotation about their diet, what they eat for breakfast and then lunch and then dinner, and do they drink soda and this or that. And then, my attendant was like, that's good, but why are you asking them about their diet? They're here for depression or anxiety or whatever it is. So it's a very different way of learning and very different skill set, but you eventually do it a lot and you get out of your comfort zone, like If you're not comfortable talking to people, you're not comfortable taking a history or examining patients, if you really want to do it, you just got to keep doing it until you get comfortable at it. So I'd say it's pretty different between the first 2 years and the last 2 years for sure.
So now, did you know orthopedic was going to be your route? I'm assuming you took an ortho surgery rotation in third or fourth year, right?
Yeah, so I kind of had an inkling that I was interested in orthopedics. I knew that I was interested in surgical specialties. I felt that I wanted to do work with my hands, and I felt that I personally wanted to have a discrete impact on someone else, meaning that if a person eventually in the future enters my care, that I can take them to the operating room, do something with instruments or implants or whatever with my hands, and then that person will leave the operating room, ideally better than when they came in. That was very attractive to me, or it just made sense in my head. And there's a lot of value in, let's say, like someone has chronic diabetes or they have some other like chronic condition, rheumatologic condition, where you prescribe medications, you track labs, you have this longitudinal relationship with patients over time. There's a lot of value in that, but it's just not something that excited me as much as surgical specialty. So surgery was kind of the forefront of my mind. And then in terms of orthopedics, I think mostly it's that I like the anatomy, and the anatomy made sense to me. It's physical, not in terms of like a strength sense in the operating room, but if this muscle contracts, it's going to pull your arm this way, or like this nerve gives sensation and contraction or muscle innervation to these muscles, and that's why your arm can do this or your fingers can do that. That made a lot of sense to me, just not intuitively, but it was like, oh, that's why that happened. So I kind of like that. And then lastly, the people. Not just in terms of specialty, but anywhere in the world, the people make the place. And I just felt most comfortable at home, happiest in the orthopedic OR with the orthopedic residents and attending. So that kind of jived for me.
Looking for your first job after training? With PracticeLink, your job search starts and stays on your terms. You control when employers see your contact information. No spam, no cold calls, just relevant jobs from verified recruiters. Join thousands of physicians using PracticeLink to take the next step with confidence. Sign up free at practicelink.com.
So let's talk just a little bit about transition to residency. So, of course, that's one of the biggest jumps you're going to have in your whole process there. What was that experience like for you as a first-year resident walking in?
It was hard. It was very hard. There comes a point where I could look at an x-ray, and if like a bone is obviously broken, I can say, okay, this bone is broken. I get it. So I could say, okay, this person either like needs to be put in a cast or needs to be splinted, or they probably need some type of operative intervention to make them better, to let them walk again, or let them use that arm or leg or whatever it is again. So that's kind of what I was getting back to about hitting the multiple choice question or knowing the answer to a flashcard question. You may know the answer, but the actual process by which that happens is completely different. So just, for example, let's say like somebody has a hip fracture. You have to go down, talk to this person, and you have to tell them that you have a hip fracture, and it's probably something that may benefit from surgery, assuming that they're a good surgical candidate. They don't have other risk factors that preclude them from having surgery. And then there's all these orders and stuff you have to put in. You have to page people, you got to write notes, you got to communicate with the team, you got to talk to your seniors that eventually work it all the way up. If they're not healthy, the medicine team has to say they're healthy enough for surgery. All these things, you walk into residency and you don't know. You don't realize that all that is happening. As a medical student on a rotation, you're kind of like following the resident a little bit, you're in the OR a little bit, you're doing this and that. But until someone looks at you and asks you to do it, you truly don't know what your job is. And I think that applies for anything, whether you're an engineer, or whether you're a lawyer, or whether you're a accountant. I truly believe that no one knows what a job or career is until you're doing it. It's a big learning curve. It's a lot of process-based things. And then on top of that, you have responsibilities and obligations to the service that you're on and to patients. And it's a huge jump.
So what do you wish someone had told you ahead of time before walking in on that first day of residency?
You're going to make mistakes, it's okay. I mean, people tell you that. You can take a horse to the water, you can't make it drink. So I think I'm going to apply that to myself. I think I was probably reasonably hard on myself when I made mistakes. Not that I would like beat myself up, but it would really kind of weigh over me. And it's residency. It's like a Swiss cheese model. There's multiple lines, multiple layers of residents and attendings or advanced practice providers, whatever, that kind of help make sure mistakes don't happen and things get catched. So mistakes are going to happen. It's going to be okay. It may be your fault. Maybe it's not. It may be something that you did or didn't do, but you're there to learn. And if you knew everything, you wouldn't be there. You wouldn't be in a 5-year residency program if you knew everything already.
So is there anything that you think the medical education could better prepare students for the clinical realities of residency?
That's pretty hard. I'm on Twitter and there's medical people or doctors or med students or whatever on Twitter. And every so often there's always a debate about whether you should make medical students take call overnight or whether you should make them go from sign out in the morning to sign out in the PM, which can be like, I don't know, let's say it's like 6 a.m. to 7 p.m. or 6 p.m., something like that. And then medical students say, we have to study, we got to do this and that. And then physicians or residents or fellows or whatever will say that's realistically what the life of a resident is. If you're in medical school, you should do that. And I think a lot of medical school rotations have you do that too. But even then, it's not the same as holding the pager or having messages from other services or nursing staff or the floor saying, hey, this patient needs this patient needs that, blah, blah. Like it's fundamentally different. I don't have a good answer because ultimately the responsibility goes to a physician, and I don't know how easily, even, myself, I don't know how easily I would just turn over that responsibility to a medical student. It's a hard ask.
And the other piece too, as a medical student, you also know in the back of your mind, it's a month long. It might be a 2-week rotation, but you're out of there after a certain point, right? And residency, it's real. It's the long haul. It's not a 2-week rotation. It's not a 4-week rotation. It's the long haul.
And especially if it's not something you're interested in. I personally think I gave it a good shot on almost every rotation I went on, but I can't tell you truthfully that I was as interested in some rotations as others. You're supposed to do your job, you're supposed to do your best, but yeah, it's a little bit harder to be as plugged in or want as much responsibility, really take on the same amount where you may perceive the stakes to be a little bit lower, where you may perceive yourself to be not stimulated.
I used to work for a medical school, and the dean's philosophy there was every student that came through, when you were on clinical rotations, every rotation, when you left on the last day of that rotation, whatever it was, your preceptor should be under the assumption that's the field you want to go in. And I thought that's a good way to put it. Give it your all. If you don't like it, it's going to end in a week or 2 weeks or 3 weeks, and give it your all. You're paying for it also, so make the most of it.
I agree with that. I don't know that everyone does that. I can tell you honestly, there's definitely some rotations where maybe I probably gave it 95% instead of 105%, but it's hard. It's certainly hard.
So how about painting a picture for our listeners? What does a typical day or week look like for a resident in your specialty?
Yeah, so I think a lot of that is very rotation dependent and your year dependent, whether you're first year, second year, or like third, fourth, fifth year. But for example, let's say someone is on orthopedic trauma rotation, typically sign out or where they talk about whatever consults that happen overnight. That kind of thing will usually happen somewhere around 6 a.m. And then either before that or very shortly after that, you should be people around on the patients that are in the hospital, whether those are patients that had surgery yesterday, whether those are patients that have been in the hospital for a few days now, whether there's someone that's ideally going to have surgery coming up, or there's someone in the hospital that you're managing for whatever reason. Those patients should ideally be seen either very soon prior or soon after that sort of sign-out conference in the morning. And then depending on what year you are, if you're a junior resident, you may be holding the pager, fielding consults from the floor of the hospital or from the emergency department or from sometimes outside facilities like a transfer center. Or if you're a senior resident, you might be in the operating room. I vividly remember sometimes the resident is operating really late. You may not get done with the OR till 7, 8, 9, 10 o'clock, 11 o'clock. But sometimes you stay late to take care of patients. And I think it's something that you should be proud of. But if you're a more junior person, I think that sometimes the time that the junior person signs out prior to the overnight person coming in, if there's a overnight system or a 24-hour call system, makes a little bit of a difference.
How about time management? How did you learn to manage time and tasks and documentation?
You just do it.
You just do it.
I can tell you confidently My first few weeks, I was so slow. I could not get a consult note done inside of an hour. And I don't know why. It's not that like I didn't understand what to do. I don't know why. I was like really slow. And then at this point in residency, I'm a little bit faster than that. I think I still write a pretty reasonable note. I don't know that I get it done in 30 seconds, but I don't take 40 minutes anymore. That is for sure. But that comes with repetition. I would say your first time changing a tire may take you 30 minutes, but if you see the guys that do it on F1, they get it done inside of, I don't know, like less than 7 seconds or however long it is. They've done it 1,000 or 1,000,000 times. So a lot of that comes with the practice and repetition. So time management's hard because it's going to take you a while to learn a new skill and learn how to do it. But eventually, when you get good at it, it doesn't take long.
Let's talk about some advice for medical students and residents. What are 3 skills every student should focus on before starting residency?
I don't know if skill is the right word, but I would say a couple things that I think are important for me. Figure out how much sleep you need to function. If you are someone that needs 8 or 9 hours of sleep to function every night, you got to know that ahead of time. And your life kind of needs to revolve around that a little bit, especially in residency. Figure out what makes you happy, whether that's spending time with friends, whether that's playing video games, whether that's, I don't know, working out in the gym or whatever. I would definitely recommend figuring that out ahead of time and trying to kind of bake that into your schedule when you can, if you can. I won't lie, there are days that are pretty busy and you come home and you just want to go to bed, and that's kind of all you have the strength to do. And then a third one, you are going to study in residency. At least in orthopedics, the majority of medical school education is not centered around orthopedics. I think they call it medical school because you learn medicine for the most part. So even some of my friends that went into internal medicine, they still had to learn and study a lot. Even though we learn the basics of medical school, the actual clinical management and different criteria and different studies and whatnot you have to know is constantly changing and evolving. So learn how to study and learn how to be efficient with that, and try to apply those things when you end up in residency, because you're there not because you know everything, you're there to learn. Some people are geniuses. I don't think I'm one of those people, but some people see something for the first time and know it and internalize it and really understand it. I'm not one of those people. I need to look at it and study at it a couple times. So in summary, figure out how much sleep you need, figure out what makes you happy, and figure out how to study.
I think that's great. One of the big questions that a lot of residents ask me on their CVs is, do I list my residency under education because I'm still learning, or do I put it under work because I'm getting paid? And I'm like, well, that makes sense. I mean, that's a good question, right? So you're right, though. It is a continuing learning process, and you're not going to know everything as a resident. Even a senior resident still learning. Everybody's learning all the time. And I always think that being a preceptor later on down the road keeps you on your toes, because again, you continue learning. You learn from those younger students that are coming through and rotating with you, and it's a lifelong process. So how important is it to find mentors, and how do you recommend students actually get one?
I think mentorship itself is a interesting topic or interesting discussion. This may be kind of a hot take or controversial thing, but I think as much as you can look for mentors as a student or resident or fellow or whatever, or even an attending, I think mentors kind of find you, At the end of the day, I think mentorships are relationships with people, between people, right? And some people are naturally going to get along better with some people than others. Some people will get some people better than others, if that makes sense. I've had some mentors where the relationship was good, but then with other people, it's like I just felt we were friends and I felt like we were just talking, right? And I felt like this is someone that I could really relate to. So put yourself out there, try to understand what you're looking for and why. And if there's someone there that can kind of help guide you a little bit, that's fine. If not, still get what you can out of the relationships you have and make sure you give back in some way. For example, if someone's investing in you in a research project or an operating room or this or that, they're going to give you an opportunity to do work and do well. Be prepared for that. Be able to complete a task that's been provided to you, or be able to, I don't know, if someone says, I'll let you help me tie these sutures, you should maybe study at home a little bit, figure out how to tie knots ahead of time, do it with your shoelace or do it with some string you have in your closet or whatever, things like that. So yeah, I think there's a difference of personal mentors and research mentors, but ultimately people are still people. Some people are best friends and some people just get along well because they're acquaintances. I don't know of a great way to change that or fix that. Just think about what you're looking for and why.
How about residency apps, study tools, digital resources? Do you have any favorites and why?
For residency applications, well, it's been a little while since I applied to residency now. I actually believe that some specialties were moving away from ERAS. Like I somehow remember reading or hearing that OB-GYN was trying to do their own thing. I don't know if that actually materialized or not. But I think it's different for like every subspecialty, or every specialty. In terms of like study resources that may be more related to like away rotations, but I'm sure there's flashcards out there, there's Anki decks out there, there's stuff on Reddit, I'm sure. And I used to say this a lot in medical school, just talk to someone that just did it. It's okay to talk to an attending who maybe is 20 years out, but maybe their experience with the application process is from 20 years ago, especially if they're not in like an academic center or they're not part of a residency committee or interviewing people, this, that. Talk to the person ahead of you because they just did it. Any struggle that you are having in med school, likely you're not the first person to experience it, and likely you're not the last person to experience it. So talk to someone that is on a similar path to you, and they probably will have some type of advice or some type of resource that you can go to. So for me, I always leaned on like the class above me or the class 2 years above me to kind of figure out how to go about things.
I love that advice. And Surviving and Thriving in Residency podcast. It's always residents and students who have been there and done that, and they have great advice. So they might give some words of wisdom on how to avoid some things on your path. So let's talk about research a little bit. For students or residents wanting to do research, how do you balance research with clinical responsibilities or classes?
So orthopedics is famous for, there's all these metrics on, I think it's called charting the match. There's all these metrics that are available of what was the average board score, what was the average extracurriculars, or how many research items did they have. And orthopedics is pretty famous for being higher up on there, same with I think like dermatology or plastic surgery, for example. What I always tell people, especially medical students, I'm like, research is great. It's good in that it demonstrates interest. It's good in that it shows your quote unquote commitment to the field. I think especially in orthopedics, I think research is important because it's a great way for somebody to get to know you and speak on your behalf. I think that's really important. But even if your research is the best in the world or it's phenomenal, if your academics are not going to hold up, then it's kind of challenging. So what I always tell people is research is good and relationships are important, but don't let that come at the expense of your academics and your scores and your grades. Because if you failed a board exam, you may have 15 first author publications, which objectively is very impressive, but that can be kind of a hurdle to come over, and you may not be able to come over that. So that's generally what I say.
What about any tips on how to pick a project, a research project?
So know your skills. I'll just say, for example, like computer science, computation, coding, or even statistics is not necessarily one of my strengths. Definitely not computation or coding or using like R or Java or whatever. I don't know anything about that. So don't seek out a project with a skill you don't know how to do. If someone wants to get you into some basic science research and you've never done basic science before, you may be able to learn it and you may be able to do it, but especially in medical school, you're not going to have as much time as you hope. So you can dedicate like a whole year to research, which plenty of people do for various specialties. So be realistic with what you're able to accomplish. It doesn't mean you can't learn how to do it, but maybe doing a systematic review or a case report or this or that is, especially for me, that's kind of what I did, was more within my grasp than building some statistical model, charting the risk of this and that with whatever patient factors and whatnot.
Let's talk a little bit about the toll that residency and even medical school takes on so many parts of your life. How do you keep your mind, body, and spirit in balance? That's a lot.
Yeah, I've missed weddings. I've definitely missed friend going out dinners or this or that. But I tell my friends this all the time that yes, I work a lot. Yes, we do this and that. But all things considered, I'm very happy to be here and very happy with the work that I'm doing. So I think what's most important is obviously the work hours are long. Regardless of whatever specialty you go into, the work hours will feel long. The demand on you mentally and sometimes physically is also long. Really pick your specialty carefully because you're going to spend a lot of time doing it. So I would generally say I'm very happy at work. And being happy at work means I'm not irritable, I'm not upset, I'm not annoyed. I'm doing what I want to do, and that makes it easier and less burdensome to do so, if that makes sense. So figure out what makes you happy, figure out what specialty that is, and, try to pursue that to the best of your ability. Because there's plenty of people, whether it's in the hospital or whether it's in different fields, whether they're in like finance or law or whatever, this or that, that they say like, oh, I hate my job, but I do it because it's a job. And I'm sure that's pretty exhausting. And my job can be exhausting too, but I love it. So it keeps me energized.
That's good. Is it hard to maintain a regular diet, or is it hard to sometimes drag yourself to the gym, or do you find extracurricular things to do in the community?
Yes, and kind of yes. I remember when I was shadowing, when I was in graduate school, I was working with a breast surgeon, and we were between cases, and he's just eating a Snickers from a vending machine. And he goes, Rohit, you want to go into surgery? First thing you should know is you eat what you can, when you can. And it's very true. If you have to be at conference at 5:30 in the morning and you overslept your alarm by 10 minutes, you better take a fast shower, and you may not be able to make coffee that morning, but you get over there, okay? So that's kind of what I would say. So we talked about diet, activities. You do what you can when you can. There are realities of residency that everybody is kind of aware of. You don't know it till you're actually living it. Anyone can tell you, but until you're actually experiencing and living that, you don't really get it. And then in terms of activities with the community or whatnot, your community is what you make of it, whether it's your neighbors, whether it's your friends, whether it's truly a community, whether that's religious or through some activity, this or that. Residency is a full-time job and then some, and you'll do what you can when you can.
Premier Health is proud to sponsor Practice Link's First Practice Fund Scholarship. Our partnership with Wright State University is helping advance medical education and support future clinicians through 12 residency and 16 fellowship programs. Through these programs, we train over 420 physicians that directly impact the communities we serve. Are you looking for an academic health system where your work matters and your growth is supported every step of the way? Join Premier Health and Wright State University in advancing academic medicine in Southwest Ohio. Visit us at premierhealth.com/careers.
How about, can you share a moment during residency when you felt burned out or overwhelmed, and what helped you get through it?
Yeah, definitely overwhelmed a couple times. Mostly when, for example, if I'm taking call and I have a lot of consults that are procedural, meaning, they need me physically there to do something, whether that means closing a laceration or exploring a nail bed or putting someone into traction or reducing a dislocated joint, things like that. Sometimes you have days where you truly get blown up and it is overwhelming, and you just gotta keep yourself focused, keep yourself organized, and do one thing at a time. When the pager goes off, I was really bad about this. I used to look at the pager like a dog, like a Pavlov's dog, like I was trained, like classical conditioning. Anytime the pager goes off, I look at it and I see who's calling or what this is about or whatever. To the point where I would interrupt myself when I was mid-procedure or mid-doing something to look at this. And it's like, you got to stop doing that, okay? Just finish what you can. Try to be as efficient as possible. Spend the proper time with the patient, explain their injury, this and that. But at some point when you're really getting busy, you got to get in and you got to get out and you got to get your tasks done. It is overwhelming, but you get better at it with experience.
What role should program leadership play in creating healthy work environments, especially for residents?
Yeah, so I think, these days, it used to not be the case of work hour limitations. These days, there are work hour limitations. I think it's 80 hours a week. I think that's across specialties. I don't know if that's only for surgical specialties. So 80 hours a week to people not in residency sounds like a lot, because people will say oh, I work a 9 to 5 Monday to Friday. That's 40 hours a week. So I think the standard 40-hour a week got doubled. So I think that there are institutional and national sort of guidelines that are within that. And then for the most part, leadership at residency programs listen to their residents. So if residents feel like that they are constantly underpowered in terms of manpower, in terms of staffing, they probably listen to them. And then additionally, when you do your work hours, you log your work hours every week, or eventually when you decide to log them, they do get reported to the GME or to the institution or whatever it is. And I don't actually know how the rest of this works, but if there's enough of violations, I think something happens at some point, but I don't really know. But I would say there are national rules to limit work hours. And then for the most part, residency leadership listens to their residents because, they're the boots on the ground.
Let's reflect a little bit. If you could go back to year one of medical school, what would you tell yourself to worry less about?
Worry less about. It's kind of a weird thing to say, but I was not okay with getting practice questions wrong or getting like flashcards wrong, because I would feel like I have to know this. I have to be able to get this test question right or wrong and this and that. And I think that eventually, not that it like ate away at me because I just did more flashcards and I eventually stopped getting it wrong, but it's okay to make mistakes. It's okay to learn from things. Don't beat yourself up. Don't beat yourself over the head. You're probably going to be okay. You managed to get into medical school, which I think most people think is a pretty challenging endeavor. So you got to be worth something, and don't define yourself by a number. It's going to be fine.
Yeah. And one more question on that line of thinking. What's one thing you learned late that you wish you had known from the beginning?
Knowledge is good. Knowing things is good. Ultimately, in residency, you work with teams and you work with other people. And even if you're the smartest person in the room, which you may be or you may not be, whatever, but being able to work with other people and getting along with the team is very, very, very important. Even if you're right, if someone doesn't like you or they perceive you to be arrogant or this or that, they may not want to listen to you. And, that may impact your career down the road. And nobody wants that. So try to be amicable, try to be personable, understand your sort of role on the totem pole, understand your role in terms of the team, and work hard and do your best and do a good job. And, people will eventually take notice, even if they don't tell you.
So as we wrap up, a couple more questions for you. For anyone listening who's struggling right now, what is one message of encouragement that you would want them to hear?
There was a time in my life when I was struggling. I kind of talked about it earlier, where I wasn't doing well in college and this and that, So I would say, believe in yourself a little bit, kind of hunker down and, chase your dreams. Sometimes they may just come true. Figure out what you need to do to get there and take the time you need, because it's your life and you have to live it. No one's going to live it for you. And I'm very fortunate to have ended up in a position where I don't have regrets, because I feel like I've gotten to where I wanted to go. But I feel like if I didn't turn over every stone to get here, then I probably would have had some regrets.
I love it. Sometimes you're your own worst enemy, right? And sometimes it's all just a matter of figuring it out and really pushing yourself just to push those bad thoughts out of your head, So how about, where can students or residents connect with you if they have questions or they want to learn more about you?
Yeah, sure. If they have questions, I think my Instagram is just my name. I think my head is pretty recognizable, so you should be able to find me just based on the photo. You can also email me if you just want to put my email in the description or whatever. That's fine too. I think those are the two good avenues. Or Twitter. I'm also on Twitter. It's the same thing. It's just my name and my photo, so you should be able to find me pretty easily.
Well, I would like to thank you again, and thanks for everyone for listening to Surviving and Thriving in Residency. For our listeners, please check out practicelink.com for free resources, including our CV Builder, our free CV reviews, the First Practice Fund scholarships, and more tools to help you confidently find your first job. I'm Charley Lowry, and thank you for listening, and until next time, keep thriving.